Hello, followers of Neuro Takeaway. Today we have the privilege to receive an outstanding neurologist, in this case, a pediatric neurologist, Professor Brenda Banwell. Brenda studied medicine and did her residency in pediatrics at the University of Western Ontario. Then she moved to Toronto, where she did her residency in neurology, pediatric neurology. Then she was appointed to the sick kids as a professor, assistant professor of neurology. Then she rose to the rank of full professor there. And prior to relocating to the CHOP, now she is the chief of neurology at CHOP in Philadelphia, Pennsylvania. She is a professor of neurology and pediatrics at the Perelman School of Medicine at the University of Pennsylvania. And on top of all this amazing CV, she is a master referent when it comes to talk about pediatric demyelinating disorders. So without further ado, let's go to the interview. Hello, Brenda. How are you doing?
I'm good. Nice to see you, and thank you for the kind introduction.
Thank you for accepting the invitation. It's a pleasure. It's a pleasure. Well, I want to know, the first question that I have to you is, how does it feel to lead the way in pediatric demyelination diseases in the world?
Well, I don't know about that attribution, but I think my first comment would be that the pediatric demyelinating disease care community is a very tightly knit group of clinicians and scientists. We communicate very regularly, as you know, with your colleagues as recently as yesterday.
Yeah.
Around the world, there is a very welcoming community of people dedicated to children with multiple sclerosis and related neuroimmune conditions. I have been very honored to serve in the International Pediatric Multiple Sclerosis Study Group, which I currently chair. And that's a wonderful, now over 170 member, 40 country represented organization. So I feel like I'm part of a big team, actually.
You had the opportunity to work at two of the most important institutions in the world in pediatrics. So how did you compare your experience in sick kids versus CHOP?
So in many respects, they're quite similar in that Sick Kids in Toronto is the quaternary level hospital for Canada. The most complex patients in the country come to Toronto for care. And certainly Children's Hospital of Philadelphia is a hospital that receives children from all over the world. I have been incredibly fortunate in both institutions to be provided with enthusiastic resources to build pediatric demyelinating disease programs in both, which has been enormously important for my patients and for the research that I've been able to do.
Okay, let's talk something about diseases. I have a question about Aiden. We see a lot of that cases. There is a very tough criteria for diagnosing Aiden, which is the presence of encephalopathy. Right. This is a mandatory criteria according to the group. Do you think that it is really so important, the presence of encephalopathy as sine qua non criteria?
I actually do, and I will take ownership of being one of the people that insisted on that in those criteria, actually. The reason, I mean, first of all, I'll preface by saying it would be wonderful if we understood ADEM at the biological level. Right now, it's a syndrome. It's a clinical constellation of findings, which can be attributed in some cases to presence of MOG antibodies. In some patients, they are MOG negative. You can have an ADEM-like presentation in rare, but in some children with aquaporin 4 antibodies. And then, of course, not very commonly, but very occasionally, you can have an Adam-like first attack of multiple sclerosis. So it's a syndrome. It's not a, at the present time, it has many contributing biologies. But the encephalopathy was critical because when you see patients with multiple T2 bright lesions on a brain MRI, at the time we wrote those criteria, a child could have presented with optic neuritis, no brain symptoms at the time, have 10 or 11 brain lesions, and it was very common for them to be called Adam. They were not encephalopathic, they did not have polyfocal deficits, they have MS. And they had a first attack of MS, and they had brain findings that confirmed distribution in space, and then often enhancing and non-enhancing, which would confirm dissemination in time. But yet they would be called Adam because there were multiple brain lesions. And parents would be told this was likely going to be a single event. Your child's going to be fine. Children don't have MS. And that was the reality when we wrote the criteria.
But on the other hand, haven't you seen patients without encephalopathy that for the rest applies to the criteria of Adam? I'm speaking about imaging and the rest of the syndrome. Or they don't exist?
Oh, they definitely exist. I think we see patients, we have many patients whose MRI appearance looks more like the classic appearance of Adam than anything else. So I'm not disputing that those patients exist. I think it was a question of what was the more important point. And I think and that always comes down to specificity versus sensitivity. We were trying to be very specific and trying to narrow a group of children with a syndrome that at its core was associated with encephalopathy. And when you do that, if you're very strict about that, you can now really narrow down a group of patients, 70% of whom will have no more attacks, a small percentage that may relapse, typically now we know with MOG antibodies, and that is enormously helpful for clinical care.
That's right. How do you see the future of this construct Adam? Because now we have Adam with anti-MOG, with aquaporin. What do you think? Do you think that in the future this construct will exist or no, or will be disappear?
I think it's going to persist actually, because syndromically it's a helpful designation. I think what will be more elegant will be biomarkers that tell us a lot more about what's really going on. So I think the MOG antibodies are very illustrative of that. I think that looking, and I'm sure we'll discover more, that will explain some of the MOG and aquaporin 4 negative children. Sooner or later, we'll discover antibodies to proteolipid protein or to, probably not MBP because they don't seem to be pathogenic, but to some other set of antibodies at some point potentially. Okay. Or we'll discover immune cell profiles that explain this particular clinical syndrome.
Okay, it will exist as a syndrome, clinical syndrome.
Yes.
Okay.
Yeah, I don't think it's a disease. It's a syndrome for which there are many contributing biologies. But syndromically, I do think it's helpful also because it causes rapid recognition of treatment options.
What are the main differences between MS and NMOSD in adults and in children?
Oh, quite a few.
The main differences.
I guess the first comment I'd make would be the typical localization of attacks. In multiple sclerosis, it's anywhere in the central nervous system. So we certainly see optic neuritis, and we see myelitis, typically partial myelitis, as opposed to extensively longitudinal myelitis like you see in NMOSD. In MS, the brainstem type of attacks more classically are internuclear ophthalmoplegia, for example, or cerebellar symptoms, whereas in NMOSD, they tend to be area postrema involvement with vomiting and sometimes midbrain and hypothalamic involvement with hypothalamic dysfunction, difficulty with menstrual cycles in young girls, hiccups, a variety of presentations that are not so common in MS at all. The prognosis is different. Untreated, now of course now we have therapy, thank goodness, but untreated NMOSD runs the risk of every attack leaving you with greater disability. The recovery can be very poor. In multiple sclerosis, the relapse recovery is often reasonably good. Long-term prognosis for both diseases, if the child continues to experience active inflammatory disease, can be poor in both. In NMOSD, it tends to be visual loss and gait impairment. In multiple sclerosis, it tends to earlier be cognitive impairment, fatigue. Eventually, of course, 20 years down the line, you can get into progressive physical disability in pediatric onset MS, but at a very different pace than NMOSD. Both need to be treated, and prompt and effective therapy is altering the course of everything I just said.
It is said that that children have a more remyelinating capacity than adults. It's a concept that many people think. I don't know if you think so, but I would like to know if we see that remyelinating capacity on imaging. We can see a reversal of the lesions. I don't know.
So I wish that was true, and I'm not sure it is, actually. So first of all, we did a study looking at magnetization transfer imaging in one of my prospective cohorts. And so what we did is we had imaging at baseline, first attack, 3 months, 6 months, 12 months, and every year after. This is a large cohort we started in 2004. And in more recent years, we were able to get high quality MTR images as part of our protocol. And these are all research scans, all done on the same scanner, each child at multiple times, which is important when you're trying to do something like this.
Yeah.
And so what we were able to do was find, let's say, for example, on the 3-month scan, there was an area that had no visible T2 lesion. At 6 months, there's a new lesion. And at 12 months, that lesion has now been 6 months of repair. And we could go and look at pre, during, and after, and find lesions where we had all 3 time points. Mm-hmm. And using MTR, we looked at the pre-lesional MTR signal, the drop in the signal that happens when it's acutely inflamed, and then the remyelination. And what we showed was the lesions do partially remyelinate, at least as estimated by MTR. They never got back, none of the lesions got back to what the tissue looked like before the lesion occurred. And the younger children tended to get closer to their pre-lesional numbers than the teenagers. And when we compared that to young adults using the same analytical technique, teenagers, by the time they hit 16, looked like adults in terms of the extent of repair, which was not great. So maybe the youngest children repair a little bit better, but teenagers do not appear to be repairing much better than adults. So that's worrisome. And then the other side, in addition to focal repair, the more global construct of brain volume loss is a big issue in pediatrics. And the rate of brain volume loss has to be measured carefully, because in the younger children, it's supposed to be brain growth. So you have to see failure of age expected growth first. They might go up, right? But they don't go up where they should. And then by about age 15, we hit our maximum brain volume normally. And our pediatric MS patients are nowhere close. They're more than 2 standard deviations below where their brain volume should be. And then by 15 to 16, there's atrophy. Now, this was an untreated cohort study, because in Canada, when we started our studies, you could only treat after a confirmed second attack. So I had quite a bit of data of children not on disease-modifying therapy at that early time point. Of course, now we treat earlier.
Yeah.
But even in the Paradigms study, which was fingolimod compared to interferon beta 1A, even in the fingolimod arm with an 88% relative reduction in relapses, there was still 0.4% annualized brain volume loss, 0.88% in the interferon arm. That's a lot of brain volume reduction per year.
Yeah.
And the 0.88 is comparable to untreated adult MS. And that was the interferon beta 1A group. And the fingolimod definitely mitigated it, but it didn't stop it. So it's just a reminder that pediatric MS is absolutely not benign in terms of the impact that we see and can measure on imaging. And I think children have a greater resilience to the neurological deficit side because they have ways to learn and use other pathways. But I'm not convinced it's because they have better repair.
Yeah, interesting. Well, I would like to know about the Antimark testing.
Right.
How often do you repeat this testing after a first positive result, and in what way this changes your strategy?
Thank you. Great question. I think one of the dangers of having a test is the immediate assumption that it guides exactly what you should do. And we've been humbled by having to learn what we think this test means. And I would suggest that we still have more to learn. But based on the data that we and others around the community have gathered, including work that we were doing in collaboration with colleagues in Brazil, actually, looking at the implications of positive MOG at first event in children. Overall, about 70% of children who are MOG positive at a first event do not have any relapses.
How much?
70%, 70. So at that first time point, a positive MOG result does not, to me, indicate putting a child on chronic therapy. We treat the acute event, but I do not believe that the antibody result should put that child at that time on chronic therapy, because the majority, 2/3, more than 2/3, almost 3/4, won't relapse. So the justification is not, in my mind, fair to put them on chronic therapy. We also know that the titer has absolutely no bearing on the likelihood of relapses based on that first event alone. What does matter is where you got the test done, because the result is, it has to be a cell-based assay. We like to have yeah. So then we looked at, so I was fortunate in this prospective study that I mentioned to you, that we archived research blood samples at all time points. And some of my patients are now 17 years in the study. And so we had serum, and we collected serum from all these time points, from all these children, and all of it was analyzed by Patty Waters in the UK in one lab using a cell-based assay in a rigorous way. And we showed that several things. One, if you look at the MOG titers in the first 12 months, they go down rather quickly. And so I think most kids' results will start to go lower and lower over the first year. About half the children that had MOG antibodies at the beginning were MOG negative by 12 months. So very rapidly went down to undetectable MOG. We thought that once you got to MOG negative, there would be no chance for relapses. That was not true. We had some children who were MOG positive, became negative, were still negative, and then had a late relapse, even when they were MOG negative. If they were still positive at 12 months, they had a 20 to 30% relapse risk. So that was higher than about the 5 to 6% risk in the ones that became MOG negative. So at 12 months, it was greater risk if you were still MOG positive, but it wasn't that high. So even having a positive result by 12 months would not have prompted me to put them on treatment if they have not had a relapse.
So you went for a second attack.
Yes. Yes. I also do not use chronic prednisone ever. I never have.
Then why should we do the testing if we won't change our strategy?
It does change your strategy though. So it doesn't get you to start chronic therapy, but the presence of MOG antibodies argues very strongly against a diagnosis of multiple sclerosis. The clinical course is different, and the treatments, as you know, are importantly different. But if you don't test early on, someone can become negative although they were positive originally, have a relapse, and now you don't know because they're testing MOG negative. So now you have this relapsing child who has no MOG antibodies at 12 or 18 or 24 months, and you don't know that they were MOG positive initially.
Okay.
So testing early on is very important for what it tells you about those children. And if you follow them, and we've done this, the children that were MOG positive at the beginning, no matter what happens to their antibodies over time, their disease course doesn't look like multiple sclerosis.
So you retest at 12 months, not at 6 months.
Not at 6 months.
Okay, okay.
But I can only say that now because I had 400 children from whom I had samples at baseline 3 months, 6 months, 12 months, and yeah. So now I don't test again until 12 months.
I have a question about treatment of myelitis. When you have a myelitis in front of you, when do you avoid steroids as the first therapeutic line? Or you always use steroids?
So the only possible time not to in North American children, which may have a slightly different infectious profile than in other countries, is in children that we think have acute flaccid myelitis with anterior horn cell involvement and enterovirus. There was some suggestion that in children with acute flaccid myelitis, that steroids may have made them worse. And the NIH published on that a couple of years ago. When we had those outbreaks of acute flaccid myelitis.
Yes, we had here an outbreak too.
Yeah, now that's hard data to judge because in those children, the ones who were given steroids, even though we knew they had acute flaccid myelitis, so we already knew it was anterior horn cell predominant, were the ones that had cord swelling and looked really, 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 really sick. So of course they did worse, but so I don't know whether the steroids made them worse, but it wasn't, certainly the sense was steroids didn't make them better.
But in those cases, you use immunoglobulin or something else or nothing?
So we did everything because these children look like they have polio, right? They are acutely, they're paralytic. They have absolutely no movement in one or more limbs. You know, it's horrible. And so I think everybody tried all sorts of things. None of it worked. We tried fluoxetine, which was proposed because of studies showing that it reduced replication of enterovirus in culture. That study didn't work.
What drug do you say?
Fluoxetine.
Fluoxetine, the antidepressant.
Yeah, Prozac. But that was a study that we did in partnership with other centers that, you know, just because remember we had a cluster, as maybe you did as well, of a bunch of children all at once. And so, you know, everybody around the country was trying to restore function in these poor children who did not typically do all that well, actually. But to your original question, there are very few indications, at least in North America, where I would withhold steroids in the context of an acute typical transverse myelitis. We would treat promptly. I'm trying to think of exceptions. We occasionally see a myelitis picture in children who've been profoundly immune suppressed for cancer care. And in those children, we make sure it's not active CMV. Because I've seen, you know, that's one context I might go straight to IVIG with and not give them steroids. And you know, but that's extremely uncommon.
Recently, there was a paper from your hospital, from the CHOP, by a friend of mine, Dr. Alves, Cesar Alves, about that some mitochondrial disorders can be the origin of an acute myelopathy. And it was very interesting for me. What do you think about that, and how do you approach this possibility?
Right. So Cesar and I are doing a big, you know, so watch for his next paper because he's writing a beautiful paper looking at all of the spinal cord imaging from that big study that I keep mentioning. That he is leading a study that's describing many children with spinal imaging that we're partnering on. So with respect to the mitochondrial story, that's really fascinating, and we have several patients now with proven mitochondrial mutations who present with what look to be an acute inflammatory demyelinating episode. Sometimes they present with a myelitis, which he described. We've had children present with what looks like an ADEM, back to our syndromic ADEM diagnosis again. We've, of course, well recognized that you can have an optic neuropathy with mitochondrial disease, often with a Leber's genetic mutation.
Yeah.
So, you know, I've been fooled before. I have one patient that comes immediately to mind who presented with, at the age of 6, with what looked like ADEM clinically, encephalopathic, multiple deficits, very long spinal cord lesion, treated with steroids and IVIG, slower than normal recovery, did not recover quickly like most children do, who then went on to have subsequent episodes, always very inflammatory in appearance, but has a proven mitochondrial mutation, and then has gone on to develop more of a Lees-like disease over time, but didn't start that way. So we think about it in all of our kids. The lactate is not always elevated. So that doesn't always give you the biological clue, although we check lactate rather routinely. And then it's really the time, it's the pace of their recovery or lack of recovery that really prompts us to go back and say, okay, we're going to look at mitochondrial genetics.
The response to treatment. Okay.
Yeah.
How often do you turn to a brain biopsy for diagnosing these disorders, inflammatory demyelinating disorders?
So the right answer is as little as I can, so I don't take out brain tissue that might recover, because in an inflammatory lesion, if we treat them properly, most of those recover, and we wouldn't have had to remove potentially recoverable brain tissue. That said, we've done several this year of children who had life-threatening demyelination, and we needed to get a prompt diagnosis because we did not know whether it was infectious, tumor, or demyelinating. And you know, one of my patients that comes to mind just from this week, she presented with a tumefactive demyelinating lesion. She was herniating both supratentorially and across the midline. So she had to have an emergency craniectomy just to relieve pressure. And because it was growing so fast, we did a biopsy. She turned out to have MOG, but we did not have it back yet. She was literally going to die. You know, the swelling was so rapid, and she'd had a funny sort of viral like prodrome. We thought this might be a very unusual infection, so we did do a brain biopsy, which clearly showed demyelination, and treated her with emergency high-dose steroids, plasma exchange, and cyclophosphamide, and she now looks totally normal. She's completely recovered. Pardon me?
It helped the biopsy the diagnosis.
Yeah. Now the biopsy, you know, doesn't tell you it's MOG, but it showed a very inflammatory lesion with extensive myelin damage. So I knew I was treating an inflammatory, not a malignant and not an infectious process. And then the MOG antibodies came back positive a few days later, which normally I would wait for the MOG antibodies, of course, but she didn't give me that option.
We sometimes have trouble diagnosing vasculitis and the differentiation between vasculitis and, you know, and it's not that easy for the pathologist to diagnose vasculitis because there is always an infiltration of lymphocytes around the vessels in all these processes. So it's
it's very tough.
It's tough, yes.
You know, my training at Mayo Clinic was in pathology, and so, you know, so I spent a lot of time behind a microscope, and you know, the true hallmark of vasculitis is that you actually show that you've got hyalinization of the vessel wall, that the endothelial cells are actually visibly damaged. It's not just the transmigration of cells across the endothelial barrier, but it's the actual damage to the endothelium directly. I'm pretty sure if we went back now and looked for MOG antibodies, we would find MOG antibodies in a sizable number of children diagnosed with vasculitis, because we are seeing that. Now, in that population, the interesting question is, do they have vasculitis and MOG antibodies, or are the MOG antibodies actually causing endothelial damage? We don't that's not clear and needs to be looked for. The typical vasculitic biopsy does not show C5b9 complement deposition on the endothelium, which would make you think antibody-mediated vasculitic disease. So that doesn't tie with MOG very well, right? Normally you would think that we might see that. But there's an ongoing, very interesting debate in MOG-associated disease about whether the antibodies are part, but by no means the whole story, and that the T cell, the MOG reactive T cells may in fact be as important, if not more important. In animals, they are. So, very hard to measure in humans because they're in low numbers, but I think that's an interesting question.
What do you think when you see contrast enhancement of the coda equina in a patient with encephalomyelitis?
So, good question. So if the conus is thickened and enlarged, it sounds like all I talk about is MOG, but that would, if the conus is involved, we look for MOG. When we see nerve root enhancement in a patient with myelitis, in our part of the world, I think about West Nile virus is one that would come up, CMV. We have been fooled before, and it's been malignancy with a disseminated dysembryonic neuroepithelial tumor. So that's not, or lymphoma. So you have to think about infiltrative processes. But infectious-wise, in our part of the world, it's and Lyme disease would be the top infectious side.
We don't have Lyme in Argentina, so we have to think in all the other diagnoses that you mentioned.
Yeah. So we look hard for all of that. And then very rarely, you can get some proximal enhancement in any patient with bad myelitis because the first 1 centimeter of the nerve roots leaves the spinal cord under the dura. So sometimes you'll get a little bit of involvement there.
In what process?
Just when someone has really inflamed myelitis, you can get a little tiny bit of the nerve root.
Centimeter.
Yeah. But not the whole nerve root enhancement. Once that happens, we're into a different category.
Thank you. Another question, what do you think, or is there any promising new drug for these diseases that you see in the future?
Oh, many. I think that the current treatment landscape, as somebody who's been treating children with MS since 1999, the change is amazing. Even with the current therapies now, the anti-CD20s, for example, just picking one, for these children who are on either rituximab or ocrelizumab, they now receive MS treatment 2 or 4 days total a year. The entire rest of the year, they live their life without a daily reminder that they have MS. They don't have to take a pill every day, although there's nothing wrong with fingolimod. It's an excellent therapy. But I'm just using the anti-CD20s as an example. They don't have to take a medicine at all the time. They feel well. For many of the children on the anti-CD20s, those smaller number on natalizumab, children that do well on fingolimod, just to name a few of the more potent therapies. These children, aren't in the hospital with relapses 3 times a year, like they used to be in 1999.
Are you using rituximab and ocre interchangeable?
So in the United States, we are not yet approved for ocrelizumab. So we can get it with a battle with insurance.
Yeah.
So that's a challenge. Rituximab, oddly, at least in our MS center, we've had very little difficulty getting approval. So I actually use more rituximab than ocrelizumab right now, although we will be part of these ongoing studies, which we're very excited to be part of the ocrelizumab trials. But it's purely between the two at this point. It's more what I can gain access for my patient.
Okay.
Yeah.
How COVID-19 changed your approach to demyelinating diseases?
Not very much, actually. Sorry, so that would be not sit in the dark here.
No problem.
So with respect to COVID, I guess I would say several things. First, we rapidly transitioned to the ability to a mixture of telehealth and in-person, so that some of my patients who are stable and didn't need a visit physically at that moment, I could examine virtually and review their adherence and making sure they didn't have any ongoing symptoms, all the things you do at a visit. So that was one transition. With respect to therapies, pediatric MS, as you know, is associated with a very high relapse rate, particularly in the first couple of years. The risk of children or teenagers having severe COVID is quite low. I counseled all my patients about all the precautions and masking and hand washing and everything else. But in terms of the balance, we did not delay or hold back on treatments because of COVID. I sit in my role as chair of the medical advisory to MSIF. I'm on several COVID committees that are looking at risks. Initially, it was risk of more severe COVID in persons living with MS, which generally did not occur, other than elderly MS patients with multiple comorbidities. But children, we did not see a particular increase in MS, pediatric MS patients with bad COVID. And then with the therapies, as you probably have read, for the most part, there was very little suggestion that you needed to alter treatment in order to mitigate risks of severe COVID disease. There was a slightly higher rate in one study of patients that were on anti-CD20 of being hospitalized due to COVID than people on any other therapy, but many other studies did not find that. So overall, there wasn't a lot of suggestion that we needed to alter our treatment because of the pandemic. And that's basically how we've managed our patients. Now, I am not using some of the therapies that you might, excuse me, think differently about, like alemtuzumab. I don't use that in kids. Excuse me, pardon me. So that one I might not have used.
But the rest, infliximab, fingolimod, no problem.
No problem.
You're using. Okay.
Yeah.
Well, the last question, I don't want to take more of your valuable time.
No problem. It's fun.
What advice would you give to a young neurologist that feels like dedicating her or himself to pediatric neuroimmunology?
My advice would be lots of things. First of all, it's an incredibly rewarding field of medicine. I think one of the most wonderful parts of my job is the fact that I know my patients so well. Once you meet these children, they are your patients until they graduate from you and to go to adult care. And as my patients know, I would keep them forever if I was allowed. But they do have to go to adult care. But you really you get to know these children in an incredibly important part of their lives, with the sincere goal of making them be healthy, normal teenagers. And that's such a great opportunity. And the kids are doing really, really well. And they need you. They need you because of the other symptoms that we've not talked about tonight, like fatigue, in some children who have spinal cord involvement, sexual dysfunction, which is an absolutely terrifying experience for a teenager. It's hard on anyone, but for a teenager to talk about sexual health with a provider and to trust you with that information and to be able to help them through it is so important. Mental health. 30 to 40% of kids with MS will suffer at least one episode of depression. And you need them to tell you when they're feeling down. You need to get them the help they need and to recognize the early symptoms. We are learning that about half, if maybe even more, of our teenagers living with MS are experimenting with marijuana. There's a whole online advocacy for marijuana as a good treatment for MS. And with it becoming legal, at least in many parts of the world, and now more recently in many parts of the US and Canada, we have a group of teenagers who are treating their disease or perceive themselves as treating their disease with a drug that acts on cannabinoid receptors, which are distributed in precisely the brain regions that are maturing as a teenager, and are in precisely the pathways that we see disrupted, the executive function, for example, as a consequence of the disease. So of course I'm concerned, but I also have my patients to listen to and to talk to, and they want to be normal teenagers. So how do you balance that? Which is always a privilege. I tease my residents that I know they're going to make it in child neurology when they can examine a 2-year-old and talk to a 15-year-old. You can do those two things, you're in the right field. So I think, my advice to people would be, do it for the right reasons, because do it because these patients inspire you and challenge you and reward you by just being part of your life. And then in terms of the scientific and clinical advances, I have had patients tell me in the last few years they forget they have MS. I never heard that in 1999 when I started. In 1999, it was a constant daily reminder, either because they had an injection or they were bruised from it and were still sore the next day, and were fatigued and had horrific flu-like symptoms 3 to 4 times a week if they were on an interferon. And if they had glutamer acetate, they didn't even know how to go to gym class without kids asking why they had bruises up and down their legs, and things that they just don't do anymore. And so, to move to an era where a patient with a serious illness can say, I actually forgot about my MS until I realized I had to come for my infusion. That's not everybody's experience, but it is an increasing experience for a number of kids living with MS. And then I think the other humbling reality is the number of neuroimmune conditions we didn't even know were neuroimmune, months ago, that we're constantly on our toes. I didn't know about CTLA-4 until I started seeing patients and recognizing that that was another one of these diseases that we need to recognize. The explosion of genetically defined hemophagocytic lymphohistiocytoses that can look for all the world like MS or an infection, but are very specific diseases. And then moving into the inflammatory leukodystrophy family, that are these amazing complex disorders that are kind of the mixture between a genetically defined white matter disease and a very dysregulated immune response to it. So the last advice I'd give everybody is, you'll never be bored. This is a field that keeps you on your toes.
Well, Brenda, thank you very much. It was a pleasure to have you here. I am sure our audience will be delighted with this interview. And I hope you come to Buenos Aires, to Argentina soon after this pandemic.
Well, I would be delighted, and you're home to one of my dear friends and very respected colleagues with Sylvia Tenenbaum, and she and I have been on many committees together. You've let us borrow Cesar, who we are delighted to work with. So at a bare minimum, I owe you to come down and thank you for letting me have such wonderful colleagues, and thank you for such an interesting interview.
Okay. Bye-bye. Thank you.
Bye. All right. Good night.